gives me great pleasure to introduce Dr. Sunil Bhopale. And Dr. Bhopale is an emergency physician who has been at Kaiser Redwood City for over 25 years.
Wow.
We're talking this morning, I've known him for about 20 of those years. He did his training in emergency medicine and his fellowship in emergency medical services at UCLA Harborview, where they see a lot of emergencies, believe me. He is particularly interested in stroke care and fentanyl management. Since 1997, he's you guys get it settled back there. Since 2017, he served as the assistant director of Kaiser Hospital in Redwood City, and he chairs a group of his peers, of all of the emergency directors in all of Northern California.
Wow.
So he is more than well qualified to speak on this topic, and it gives me great pleasure to introduce him. I first met him when I was working at the health department, and Dr. Bhopale threw the short straw and was assigned to our medical advisory committee. And we worked together actually on setting up the stroke system in San Mateo County. So it gives me pleasure to introduce Dr. Bhopale to you, and thank you for coming this morning.
Thank you very much for the kind introduction, Jan, and so I really appreciate that. So a couple of things. First of all, can all of you hear me okay? So I want to make sure my voice is loud enough. The room's a little bit big, but that's fine. Okay, great. And then can all of you see these slides okay as well? Is it too dark, light, appropriate? Okay. So this session is meant to be for you. So I want all of you to just think about what I'm presenting. This is an interactive session, so at any time, if any of you feel free, you want to just jump in and ask a question, please feel free to do so, and I'll pause. And it's meant to be interactive. I do have one favor to ask, is that when I've given talks like this in the past, sometimes people will start to launch into personal stories, or I had a stroke, or my friend had this. So maybe you could share those at the end, because sometimes it can be, it'll make the session a little bit longer, and there's some important material I'd like everybody to see. So I'm very pleased to be here. This group in particular is very important to me. So my mom lives in independent living in a retirement community in Foster City. And so we'll talk about her a little bit more as we go through this talk and what happened to her. But seeing this demographic here and being in the emergency department, I'd say about 2/3 of the patients that get admitted to the hospital are 65 and above. And so we see a lot of folks that are older, but we take care of all different age groups. And stroke is not just unique to older folks as well. We do see young people with stroke. And we'll talk about a case that I just had yesterday about that as well. So, with that being in mind, thank you very much for having me here, and we'll get started. So, this talk is called New Hope for Stroke. I'll be talking at a high level what stroke is and what's new in terms of development for stroke. So first things first, you'll see some proprietary materials in the back. You're welcome to take any of those materials if you like. I'm not here representing Kaiser or any particular drug company, such as, well, I don't want to name names, but any particular drug companies or mechanical device companies or anything like that. So I have no disclosures, and I don't work for any proprietary company outside of my hospital group. So, okay, so there's a couple of objectives here. So I want all of you to understand exactly what is a stroke. So some of you may have had personal experience with a stroke, or you may have friends or family members. We'll talk about that in a moment. Describe why strokes happen. Discuss the typical signs and symptoms of stroke. Review what you should do when calling 911, and that's really important as well. And then we'll talk about treatment options for stroke and how the science of stroke has evolved. Even in my brief career in medicine, even though I've been doing this, let me see, I graduated from medical school almost 30 years ago. What we can do for stroke now is miles apart from what we could do in the past. And then highlight preventative measures, of course. So the best treatment, obviously, or the best situation is not to have the stroke in the first place. Okay, so why should you care? So first of all, before I jump into statistics and epidemiology and all that type of thing, how many of you, and it doesn't have to be you personally, know of someone who's had a stroke? Wow. So almost everyone has raised their hands here. So this is something that either you've seen personally, either in yourself or in a family member or in a friend or something like that. So stroke is unfortunately pretty common. It's the 5th most common cause of death in this country. It is the most common cause of disability, though, and that's an important distinction. So unlike a heart attack where a lot of times people might have a heart attack and then that's it, they're gone, most patients will survive a stroke, okay, which is good, okay? But what we found is that about 30% require assistance for caring for themselves in some way. Some situations they could do kind of like they did before, but not quite the same. 20% require help to walk, and about 70% will have a reduced ability to work or function. Stroke does primarily affect people who are older, those over 65, but we do see it in younger folks as well, and even in children. Sometimes we'll see kids with strokes. But unfortunately, the risk does double with each decade over age 55. And then interestingly, for people who are under 65, men have strokes more likely than women. But then, because I think women in general probably live a little bit longer than men, women tend to have strokes more than men after age 65. Okay, so what is a stroke? So take a look at this. We all know what this is. This is a tree, right? And as you can see, there's various branches in here. And you've got the trunk, and then you've got the branches, and then you branch off into little branches, and then you've got the leaves. So I love the analogy of thinking of the brain like a tree, okay? And then just like the branches, if you think of them as the nutrients and the blood vessels that supply the brain, or the leaves of the tree, you've got the blood vessels that supply blood from the heart up into the brain. And so obviously the heart is the pump that gets the blood up to the brain. And then we'll talk a little bit more about the anatomy of the brain and the blood supply to the brain. So this is really important. Stroke is a brain attack. So we all know the term heart attack. We all know what that means. That means a part of the heart is not getting enough blood for whatever reason, okay? And there's a couple different potential causes. So when we talk about stroke, I want you to think of it as a brain attack, and that's the term that's recommended from the American Heart Association. So the term, that means the blood supply to a part of the brain is just interrupted for whatever reason. And it can be due to a blockage in a blood vessel, and we use the term ischemic, okay? You may hear this term, or you may have heard of this term before. And that's by far the majority of the strokes. And that's due to a blockage in that blood vessel, okay? And so here you can see what looks like normal brain, and then you see that dark part right there. This is ischemic stroke, where there's some kind of blockage, and so that part of the brain starts to die off a little bit right there. Okay, and so that's called ischemic stroke. Another kind of stroke is when there's a tear in the blood vessel, or a hemorrhagic stroke. So where a blood vessel bursts. Okay, and so the blood that would normally be going to that part of the brain is instead going to surrounding tissue into spaces where it's not supposed to be. And so that blood is being diverted or rerouted. So any questions about this? Okay, let's keep going.
Yes, I do have a question.
Of course.
The burst blood vessel, the
Hemorrhagic.
hemorrhagic, is that the one that more often does result in death, instant death, rather than?
That's correct. Yeah, it does. And the reason being is these strokes, first of all, well, the most common reason is that blood that should have been inside the blood vessel starts to go into the brain and starts to squish the brain because the heart keeps pumping that blood, right? And then it ends up pushing that part of the brain. And depending on where that blood vessel is and how much blood has escaped, that can affect the outcome. But those tend to be more devastating in general.
Is that also called a brain bleed?
Correct. Yeah, and there's different kinds of brain bleed, but yeah, these are the ones that tend to be more fatal in general. The ischemic ones are, like I said, about 85% of strokes out there, and that's by far the ones that most people tend to do relatively well. Again, it depends on the size, the location, and so forth. Okay, so what happens? I mean, why is blood so important? So what are two key nutrients that blood supplies to any part in your body, any organ? Oxygen, number one, right? And what's the other thing?
Take away CO2.
So I see some cookies back there. What's in these cookies? Sugar, yes. Glucose, okay? So yes, so you need sugar. Okay, that's what the doctor said. So, so you do need sugar, but it's absolutely vital to have both oxygen and glucose. So that's super, super important. And so you can have all the oxygen you want, but if you have no glucose, the brain or any tissue will start to have some serious problems. So strokes are sudden, and this is really important. Sometimes, how many times have you heard or you talked to someone and then their speech might suddenly kind of seem a little bit different, or it can be kind of slow and then it just kind of comes back to normal, and then like that, and then it kind of goes back. It tends to be pretty sudden, or people will say, I was walking and all of a sudden I had difficulty moving one side of my body or the other. But it happens suddenly. And I use this analogy a lot when I'm talking to patients. I'll say, did your symptoms start all of a sudden, just like that? Like something literally threw a switch. Those strokes tend to be sudden, and that's really an important distinction. They don't tend to be gradual, where, so there is a particular type of stroke that can cause a headache. People say, yeah, it kind of came on gradually, and started off a little bit, I woke up with it in the morning, and by noon it was a lot worse, but it kind of just took a little bit of time. No, strokes happen usually pretty quick. So the origin of the word, and why do we call it stroke in the first place? It doesn't seem to make a lot of sense, but it comes from the German word strike. So, and then anyone who had a sudden disability was thought to be struck down by the gods. Okay, so that's what the word stroke where it comes from. But that's why a lot of times you'll hear the term brain attack, because that makes a little bit more sense from a global perspective here. Okay, so as I said, most strokes are due to a blockage, what we call ischemia. And there's two kinds of blockages. There's a plug in the vessel or a clog in the pipe, okay? And so if you see this right here, this is a normal blood vessel, and it's actually lined with muscle and different layers. And this is what you would hope to see in a normal blood vessel. And then here, if this person has a history of high blood pressure or diabetes or high cholesterol levels or lipid levels, then you can start to get plaque formation inside that blood vessel. And then what can gradually happen is that clot, or not clot, but the lining of the wall starts to build up and get thicker and thicker, meaning the passageway for the blood becomes narrower and narrower. So that is what we call thrombosis. Okay, so it's a slow development of a narrowing of the pipes, if you will. The other type of stroke that you see is what we call an embolism, where a clot can get thrown, typically from the top of the heart. And how many of you have heard of a condition called atrial fibrillation? Can you raise your hand? Okay, almost all of you have. Okay. So atrial fibrillation means quivering of the heart, and we'll talk a little bit more about that. But most of those patients who have atrial fibrillation, not all, but most, are on some kind of blood thinner. And the number one reason why they're on that blood thinner is to prevent a stroke. And because what happens is in the top of the heart, a small clot can develop, and then it can just fly off, and it can go from from the heart up into the brain. And then if it does that, you can get a stroke, which is obviously bad news, and you want to avoid that as much as possible. So those are the two different ways you get blockages in the type of stroke. So we have a CT scan here, and you can see right here, right away, that there's an abnormal side here. So this is the right side of the brain, right here. So if you're looking at the foot of the person up towards the top of his or her head, these black areas right here are normal chambers within the brain, what we call ventricles. And then you see right here clearly there's something abnormal here. If you've ever left, so this is the part of the brain that suffered a stroke. If you've ever left a piece of fruit and it gets kind of moldy on one side, or you left in the fridge for too long, you pick it up and it's like, oh, that doesn't look so good. You know what I mean? So what happened is that was getting starved of either oxygen or water. And so what happens? The integrity of that material starts to degrade. So what you see here, as I said over here, this part right here, these narrow little slits right here, and then this part right here, these are ventricles. Those are mostly filled with water, what we call cerebrospinal fluid or water. So what does that look like? Kind of looks like that, right? So that's what happens. The integrity of those blood vessels, the integrity of that brain tissue has started to degrade. And so that's why that looks like that. Now, when a stroke acutely happens, that CT scan will look perfectly normal because it just hasn't had time. It takes time radiographically for these changes to appear. So it can take a couple of hours before you start to see something abnormal. Right here, this is an MRI, and it shows, you can clearly see that there's something wrong on the left side of the brain here. So it's this white area right there, and that indicates an acute stroke. All right, so there's 3 reasons for we talked about ischemic strokes. Now I'm going to pivot a little bit and talk about the more serious one. They're both serious, but the ones that tend to be a little bit more problematic, which are the hemorrhagic strokes. So these can be due to 3 different reasons. So you've got what we call an AVM. So if you look right here at this, you've got normal blood vessels, and they can go from one area of the brain to the other. But then you see this little mishmash, almost looks like a bag of worms right here. And so these are congenital things. And these are something you are just typically born with. And it's something you may not even know about. You can go through your entire life, you can pass away, and never, ever have a problem with this. But sometimes, for some people, it'll rupture for whatever reason. Typically, in the setting of high blood pressure. Here, you've got another different cause of abnormal, or what can cause bleeding in the brain. And you may have heard the term aneurysm, and there are different kinds of aneurysms. But an aneurysm is a saccular, it looks like almost like a bulb or like a little, think of it almost like a little balloon that's attached to that blood vessel. So because it's not a normal blood vessel, it's thin-walled typically, it's more prone to rupture. When I was thinking about this on the way here, one good example of something like this. So all of us, when we take a shower in the morning, we turn on the faucet or you turn on the water in your sink, and that's positive pressure. That's the city supplying positive pressure, getting that water to your house, okay? An aneurysm is something shouldn't be there. So if you've ever seen what happens with a fire hydrant, think of a fire hydrant as an aneurysm. What happens if somebody accidentally drives into a fire hydrant? Water goes everywhere, and that's high pressure, right? You've seen that, what happens there. So that's what happens when an aneurysm bursts. It's just water, in this case, the analogy would be blood, starts just spurting everywhere, and it can cause a lot of problems, as you can imagine. And then the third, and we see this typically as people age, is weakened or thin blood vessels. And so just as people get older, blood vessels, they tend not to be quite as strong. And so that's the third reason why we see bleeding in the brain. Any questions about this so far?
Any way to prevent the weakened blood vessels?
So through lifestyle modification. And so being as active as much as possible, healthy diet, trying to reduce risk factors for stroke, and we'll talk about those in a little bit, but high blood pressure, diabetes, those kinds of things. But absolutely.
I did want to go back to the, when you spoke about embolisms
Yes.
and atrial fibrillation.
Correct.
What's the connection between fibrillation and clot formation?
Okay, so let me talk about that a little bit then. So fibrillation, so normally the top of the heart, you've got 4 chambers in the heart. I don't have a picture of this, but I can explain just very briefly.
Yes.
4 chambers of the heart, and your heart normally beats in a sequence. The top chambers squeeze the blood, and then the bottom chambers squeeze the blood. So the top chambers squeeze the blood from the top of the heart to the bottom of the heart, those 2 bottom chambers. And normally when they do that, they squeeze almost completely. It's a nice, well-synchronized pushing of all that blood, okay? And then in the bottom chambers, you've got your right ventricle, which sends blood to the lungs, and then you've got your left ventricle, which sends blood to the rest of the body. So what happens is in atrial fibrillation is that the top of the heart, instead of squeezing the blood out, it tends to quiver. And fibrillation literally means quivering, okay? And so the blood actually still can go through, but it doesn't get that kick, that push from the coordinated muscle contraction. So then what happens is clots can form in the top part of the heart. It's been known for almost forever that this happens. And so as a result, you can either get tiny clots that can go to the lung, as I said, in the right ventricle, or tiny clots that can go up into the brain or other parts of the body for that matter. So when people are on blood thinners for atrial fibrillation, it's not only, by far, the majority of the reason is to prevent stroke, okay? But you can also get clots to the small bowel, to other vital organs, and then you can start to have symptoms and problems related to that. So that's what happens. You're not getting complete squishing of that blood. And blood that tends to sit or pool tends to clot. That's the issue. Yeah, you would think through the heart it should just kind of go right through, even though if it may not be pushing all the way through. But blood can actually just sit there, especially if people have high cholesterol or other factors that make blood more prone to being a little bit thicker. It can just, blood has a tendency to actually clot very quickly. And for all of you, we've all scraped ourselves, you notice very quickly that the blood will stop bleeding, or the abrasion or the laceration will stop bleeding, usually pretty soon, unless the blood vessel is cut.
Thank you.
Okay, so this scan looks a little bit different. So if you remember, this is a CT scan and an MRI showing a hemorrhagic stroke. So you remember before it would look black? Remember those ventricles I pointed out over here and here and over here? And now you see it over here. This looks bright white. And so that's blood. And it's actually some components of blood, specifically the iron in there, that makes it look bright white like that. And so that's not a good thing. And so this one, as a matter of fact, is starting to actually push. If you can see, it's normally this is 100% symmetric. It goes up and down like that. It's starting to push that brain tissue over to this side. So even though someone who has a stroke like this does not mean end of the world, and that person, in theory, could regain actually pretty good function too. Again, it depends on how quickly you get to the hospital, how quickly they identify what the problem is, and go ahead and treat it. This is an MRI over here on this side, and it actually looks the opposite. See, it looks a little bit darker. The other one, when it was the ischemic stroke, it lit up. This one, it's the exact opposite. It's a little bit darker here.
Does that actually, what was I going to say? Never mind, I forgot. Sorry.
Yeah.
I'm thinking too much.
It's okay. If it comes back to you, just let me know.
Oh, the spinal fluid.
Yes.
As that closes off, does that do anything to the spinal fluid? Because I noticed on that side,
Yeah.
you said the blacks and the
Right.
blue things look like spinal fluid.
Correct.
Does that close that off?
It can. It can sometimes cause, and then that will start to cause swelling of the brain. Because you have little factories that make that spinal fluid in the brain. They don't shut off during a stroke. So they continue to make that spinal fluid. And so then it just, and the brain is in what? The skull, right? It's a hard enclosed object. So that can start to cause swelling in the brain. So, yeah. excellent question.
So you're showing us CAT scans and MRIs. Are there times where they would do one or not the other?
Oh, yeah.
Or why do they do both?
We
or
always
do they not do both?
So CT scans are easy to get, they're
Yeah.
quick, they take about less than 2 minutes, and I can get a CT scan done. MRIs, you have to sit for 35 minutes in a noisy scanner.
Right.
If you have metal in your body, certain types of metal, you can't have it. And it takes just a lot longer. Now, MRIs give us much more detail than CT scans. However, we can take care of an acute stroke with a CT scan, and that's almost always the only information I need. Now, sometimes people come in with vague symptoms. I think it might be a stroke, and a classic example is dizziness. Dizzy. What does dizzy mean? If you know what dizzy means, please tell me, because everyone has a different version of what dizzy means. So dizzy means, if you're lying down, you sit up, or you stand up, you can feel kind of lightheaded. Or sometimes people say, I feel dizzy when they're walking, but they're walking a little bit kind of funny with an unsteady gait. Or dizziness can also mean, I know I'm going on a tangent, but this is important. Dizziness means I'm lying down still, but then if I turn my head, or if I look in certain directions, whoa, it's like vertigo, like things are moving around. And so the etiology or the causes of those different kinds of symptoms I just explained are vastly different.
Mm-hmm.
So when someone says they're dizzy, oftentimes I end up needing to get an MRI because the CT scans are really good at showing probably about the top 2/3 of the brain, but the back of the brain in particular, it's not as good, and the MRI is much more helpful. So I end up getting MRIs a lot in patients who are dizzy.
Okay, thank you.
Let's see. Okay, this is a really, really important concept. So if you get a stroke, is it the end of the world? I want to be very clear. The answer is no. Okay, that's super, super important. Okay, so if you can imagine this, you've got your ischemic core and what we call penumbra. So do you see how that's a dark red dot there? So if you imagine, if you cut off the blood supply to a part of your body, you've got a certain amount of time before it starts to die off. So that red part right there, the dark red, is the part that's died off. That's unfortunately gone. But based on time, and if there's what we call collateral circulation, so maybe say the blood vessel right up to here just got cut off, so unfortunately that part died. But this part around may have other blood vessels that are still working, and so it's at risk for dying if you don't get that clot fixed or stopped, or can someone get that clot dissolved. But there's still what we call viable, the term is penumbra, that's the term that we use. And so a lot of times you'll see patients come in and we give treatments for the stroke and they start to get better, but what we're oftentimes recovering is the penumbra. The part that's died off is died off. So you may have heard of the term TIA, or transient ischemic attack, okay? So what that means is you didn't get to this point in the first place where the tissue actually died off. So there's a warning sign. So instead of the blood vessel being either 90 or 100% blocked, maybe it's 70% blocked. And then if you, say for example, got dehydrated for whatever reason, now you don't have enough blood flowing through, then all of a sudden you go, gosh, I can't move my hand as well, or I'm having problems with my speech, or I'm having problems with my vision. Then what happens is, if you can restore that blood flow for whatever reason, then that tissue that would have died off is actually saved. So that's a really important concept. And so a lot of times people, when they come in with chest pains, as an analogy, and they say, gosh, I get this discomfort, and I walk for 20 minutes, for let's say 100 feet, and I get this pressure in my chest every time, and then I stop and it rests. So that's kind of like a warning sign. That could be what we call angina, which is kind of a cardiac equivalent, or the heart equivalent of what we're talking about happening in the brain. Okay? So that's what I was talking about right there. So TIA stands for transient ischemic attack, or it's a mini stroke, okay? I don't like the term mini stroke, because stroke to me by definition means something had died off actually in the brain. But we use the term mini stroke, it's a little bit easier to understand. So TIA by transient means short-lived, ischemic means there's a blockage in blood flow, and attack means it was sudden. So most TIAs are usually 2 to 15 minutes in duration. It's the same risk factors as a stroke. So if someone starts to get these kinds of symptoms that are suggestive of stroke, and we're going to go over what those symptoms are, then you need to pay attention. So as I said, these are potential warning signs of an impending stroke. And so it depends on your risk factors, but it does put you in a higher risk category of having a stroke than obviously if you didn't have it. And as I had mentioned earlier, there's no core dead tissue yet. That's super important. So, but for all intents and purposes, we treat it as a stroke, as a warning sign. Because if you had, like, I don't want to use the term hiccup, but if you had something that went wrong, chances are next time it may not go your way, and it might end up being more serious. And the classic thing is, we're all human beings, and sometimes I get a little chest pain here, and it's like, oh, it's probably nothing. But then I put on my analytical hat, and then I think, what happened? What did I do today that may have done this? Or I get a little bit of abdominal pain. Whatever. Okay. What do? I blow it off. Okay. I get it. Okay. But when we talk about some of the symptoms for stroke, these are different, and we'll talk more. And this is what I want to educate you about, or educate you on, is so that you're aware. It's like, this is actually something more serious, and we have to pay attention. Okay, so why do strokes happen? So we talked about blood vessel disease, and we've kind of gone over some physiology. Age, unfortunately, is a risk factor for stroke, as we've talked about. Diabetes. So we talked about how glucose is so important, right? Your tissues need glucose. So just like anything, too much of a good thing is not good. So too much glucose in the system actually damages the lining of those blood vessels that we talked about earlier. It can lead to plaque formation. And so it's unrelated, but many of you probably know diabetics, or you may be diabetics yourselves. And so one of the signs I look for if someone who may have unrecognized diabetes is one of the things. These are people who typically have much higher sugars for a longer period of time. I'm not talking about they're like 150 or 140 for years and years. I'm talking about 200, 300, and that can even last for a couple of months. Is that they start to have difficulty and pain in their feet and in their toes, and because the blood vessels there are smaller, so it's harder because of the sugar damaging those blood vessel walls. And you can actually even see. Now I'm going to teach you a little bit of medical school stuff, but you actually see loss of hair there because on a microscopic level, it's causing vascular changes so that hair can't even grow on there. And so it's like, oh, that's interesting. So these are little things that you learn that kind of tie everything together in medical school, which makes it so wonderful. But anyway, I'm probably digressing too much, but diabetes is a risk factor for stroke. So just like what can happen in the feet or in the hands, can also happen in the brain as well. High blood pressure, obviously, too much of a good thing is not a good thing. So you've got to have a good amount of blood flow to the brain. But if that blood pressure is too high, that can obviously cause some blood vessels to either burst. Sometimes, we think of high blood pressure, you think of that analogy I talked about when the car hits a fire hydrant and then blood exploding everywhere. On a microscopic level, though, that pounding of blood actually can start to cause inflammatory changes in the blood vessels in the brain and cause that thickening of the arteries, too. So that's what happens on a microscopic level. So high blood pressure is definitely a risk factor for the ischemic stroke, or the blockage type. Smoking. So you're inhaling carcinogens. You're inhaling particulate matter, like you're inhaling noxious chemicals. So that's going to cause changes on a microscopic level that will lead to damage in blood vessels supplying the brain. High cholesterol, that obviously makes sense. Family history, unfortunately, it does tend to run in family. Sleep apnea. So what happens is at night, sleep apnea means people fall asleep and then they temporarily pause their breathing. And it can be for a few seconds, it can be sometimes for up to a minute, and they may not even know it. But when they wake up in the morning, they tend to be a little bit drowsy. And sleep apnea, we tend to think of it typically in more obese people, but that's not always the case. We've seen skinny people with sleep apnea as well. And it has a lot to do with the anatomy in the back of your throat. So what happens in sleep apnea? So if you pause your breathing, there's two things that your brain needs. Glucose and oxygen. Right, so it's not getting oxygen, right? So what happens is the brain vessels start to compensate for a little bit, and they can start to clamp down a little bit. And you can also get what we call those microvascular changes where the blood vessels start to thicken a little bit. So that can be a risk factor for stroke. And then, of course, if you've had a stroke, chances are you might have another one. So that's a risk factor.
Question about smoking,
Yeah.
is that just tobacco or also marijuana? Don't know.
So, good question. It depends on how much and how often, right? Okay? So, and then there's also, you know, the edible forms. But to your point, it's inhaled. First of all, it's inhaled. So, we don't typically think of marijuana as a risk factor for stroke, okay? But just inhaling, you know, fumes and a burning of leaves, that combustion of plant material, regardless of, you know, if it's tobacco, if it's marijuana, it can, in theory, cause an increased risk of stroke. But no one, I'm not aware of any literature that's looked at specifically as marijuana as a risk factor for stroke. But in theory, it's possible. Yeah.
Look into edibles.
Right.
And there are companies who deliver in the park.
Good question.
And that's risk of choking.
Yeah.
Yeah,
Right.
before we,
There's always a trade-off.
before we get too far past the mini strokes, like
Yes.
you had, the term subarachnoid,
Yes.
which I thought was like a mini stroke, where does that? is
So
that-
that's actually a really bad kind of stroke. That's a hemorrhagic stroke. And that's, if you go, there was a picture of an aneurysm. It looked like that little balloon I was pointing out where the branches of blood vessels. So yeah, that's actually a pretty devastating type of stroke. Those patients tend not to do well. So that has to do with a rupture of a blood vessel at the base of the brain where that blood is actually going everywhere in those ventricles that I talked about, and then that causes a global increase in blood pressure in the brain. The blood is actually an irritant. When blood is not in a blood vessel, it actually, the body doesn't like it. And so let's just say you're involved in a car accident and you rupture your spleen, okay? This happens. So all of a sudden people will come in, if I push on that person's belly, it's like you could bounce a quarter off of it because that blood is so irritating. It irritates the lining of the abdomen. So when that happens in the brain doesn't like it. It starts getting irritated and inflamed in there. And so typically you start to see wild blood pressure changes and also people come in complaining of a severe headache. It's a type of stroke that people unfortunately tend not to do well. That's the most devastating form.
So it's not a mini stroke.
That is not a mini stroke.
catastrophic.
No, mini stroke is, so we talked about ischemic and hemorrhagic. In theory, you could have a TIA from a hemorrhagic stroke. Those are pretty rare. It's almost always the ischemic variety. So by definition, an ischemic TIA means the symptoms are completely resolved. You can have a small, tiny little bleed and make a full recovery. It doesn't happen often, but it does happen. So we've talked about stroke, a new hope for stroke. With the treatments that we have nowadays, plus aggressive pursuing of medical care earlier instead of later in the time course, then that can make a huge difference.
I'm looking forward to the hopeful part.
Sounds aggressive.
I got a question.
Yeah.
If you feel that hardness in your stomach
Yeah.
and getting those bad headaches, should they go?
No, so that's in the setting of a trauma, what I was talking about, or
Okay.
stabbing or something like that. So
Oh.
now, there are other things that can cause that kind of irritation. I mean, but if you get all of a sudden diffuse abdominal pain and somebody doesn't feel right, you should probably just see the doctor regardless, okay? And we'll talk about the headaches in a moment. But the classic subarachnoid headache is somebody comes in, and listen, I see 10% of patients come to the emergency department with a headache. And we'll talk about strokes and headache in a moment. But I'll say, and I used to ask this question, but I don't ask it anymore. But the classic definition of a subarachnoid hemorrhage, like I said, this is a very devastating type of stroke. Is this the worst headache of your life? And almost always people say yes. But if it's a young person who has a history of migraines and feels just like their previous migraine, except this is the worst one, and even if it came on pretty quickly, chances are I'm going to just treat it like a migraine. Now, I've been doing this for 25 years, and I have a pretty good gestalt. I'm a human, so I do make mistakes, but I have a pretty good sense. But when somebody says, oh, I was fine, and it felt like a thunderclap, sometimes it can happen after a sudden stressful event, or it could be post-coital, for example, after intercourse or something. Worst headache of life. that's a totally different story. It's like, okay, we're getting you to the scanner, we're gonna need to do a bunch of tests to figure out whether or not you had a severe subarachnoid hemorrhage, so. Yeah,
What about a blood clot following surgery?
that's definitely possible, yeah. So typically, say for example, you're taking a blood thinner for whatever reason, maybe you have a stroke, you've got atrial fibrillation, we'll pause blood thinning medications for surgery, because when you cut, you're gonna bleed, generally speaking, right? So you don't wanna have that in your system. Hip replacement, knee replacement, that type of thing. But we try to get patients onto blood thinners as quickly as possible. It's rare that the surgery in itself causes a clot to form and then cause a stroke, but it is possible. Especially because what happens when you had surgery? What happens? You lie in bed a lot. You tend not to move. Okay, so what happens? Blood tends to pool in different parts of the body, and then you're more prone to developing stroke.
Is there any correlation between inflammatory diseases that might set up a stroke, such as rheumatoid arthritis?
Yes, so I'm not sure about rheumatoid arthritis. There are certain autoimmune diseases, as you implied, that do. Lupus is one. I'd have to check on some other ones that can put you at increased risk for stroke. However, those tend to be pretty rare. And again, those patients are closely followed by rheumatologists or by their primary doctors to make sure that there are no consequences of that. But it is a theoretical risk. Any inflammation in general is something that's not great. Sometimes the inflammatory response is wonderful. That's why the body has it. You need it to help fight off an infection or to treat a certain condition. But too much of anything is usually not a good thing. Question back there.
Can I ask you a question about how, if a person has had one stroke, what's the percentage of having another one?
I think it depends on what kind of stroke that person had. So it's hard for me to put a percentage on that. I'd have to get back to you on that, but it's definitely higher than it's difficult for me to say only because it depends on what kind of stroke that person had and what are the events that led up to it. But they're certainly at higher risk, though. Any other questions? Okay, let's keep going. How are we doing okay in terms of time, Jane?
I think we are fine.
Okay, good. Okay. So, why do strokes happen? We talked some about risk factors in terms of high blood pressure, diabetes, that sort of thing. Also, in terms of medications, there's certain medications, aspirin, and many of you might be on a drug called Plavix or clopidogrel. That's another medication that makes you have an increased risk of bleeding. You'll see a lot of commercials for these drugs. Eliquis, Xarelto, not so much Pradaxa because there's a generic form of that now, so drug companies aren't making money off that. Coumadin has been around forever. That's been, well, when I say forever, it's about 70 years or so. And so these are powerful blood thinners. But if you're taking a blood thinner, obviously you're at increased risk for having bleeding in the brain. Age, high blood pressure, smoking, excessive alcohol consumption. So your liver makes clotting factors. And if your liver starts to not work so well because of heavy alcohol consumption, you may have heard of the term cirrhosis of the liver. That means pickling of the liver, basically. So it just doesn't work as well as it used to. And so what ends up happening is it doesn't make clotting factors as much. And so one of the ways we track the severity of liver disease is actually how quickly does your blood clot. If it's not making clotting factors, you're going to be more prone to bleeding. High cholesterol, and then chronic kidney disease. And we see this a lot. It has to do with some biochemistry, but the way the kidneys work, if they're not working so well, people are more prone to having hemorrhagic strokes.
Question. Those medications, I take aspirin occasionally for thing, but I don't take it all the time.
Sure.
How much aspirin is a risk factor?
We're talking, well, so when we say aspirin, in general, aspirin is a really well-tolerated drug. So you've heard of the term baby aspirin, 1 milligrams, and then the regular aspirin is 325. So we're talking about the higher doses of aspirin, typically 325. Okay, number one. Number two, 1 aspirin will knock out the platelets. That's a part of your coagulation pathway for 1 week. So if you take 1 baby aspirin on Sunday, That's effective for the rest of the week,
Oh,
actually. But we take it on a daily basis because we found, especially with coronary artery disease and also with stroke, it's just so effective. And the risk of bleeding is actually quite low compared to some of these other drugs. These warfarin and these anticoagulants, much more likely to cause bleeding than aspirin. But I've had patients who come in, we'll talk about my mom in a second, but she's on aspirin. She fell and she's got these huge bruises on her leg, and that's the aspirin. I just said, but I said, you gotta keep taking it because, well, we'll talk about her.
Well, the other question I have about that is, so these are blood thinners, basically,
Correct,
right?
correct.
And that would make hemorrhaging more likely because it wouldn't clot.
Correct.
Okay.
Correct. So the reason though people are taking, let's think about why they're taking it. So
That's what I was thinking.
yeah, so if you've got, say, normal coagulation profile, okay? Now, if you have, let's say, a heart issue or a stroke, and it was due to ischemia, okay, that means your blood was coming up a little bit thicker, then we'll put you on aspirin so that you're now, instead of the more tendency to have more blood clots form back to the middle, okay? What we don't want is to put you into the other category where you have a propensity or a tendency to bleed, okay? So aspirin is considered much safer to bring you to kind of like more of a middle status, as opposed to these other drugs, which typically we use in atrial fibrillation, or you may have heard of the term pulmonary embolism, a blood clot in the lung, or DVT, deep venous thrombosis, a blood clot in the leg. That's when patients go on much more powerful blood thinners. So I have a family member, for example, who's got a blood clot, a superficial clot on one of his veins. But the problem is, this is the second time it's happened, so now he's taking Xarelto. And so I was just talking to him yesterday about it, and he said, yeah, it's a bummer. I have to be careful when I floss, that I'm not too aggressive, and all of a sudden I'll start to bleed, you know, those kinds of things. So, yeah.
So, I was just going to follow up. So, the actual risk factor is the medication, but they're taking the medication because of another problem.
That's exactly right. Right. So you have a problem where your blood is a little bit thicker, or there may have been a thrombus, the blood vessels got a little bit thicker. So to thin it out so you have a less likelihood of forming an ischemic stroke, you take that aspirin. So it puts you back a little bit more, it kind of counterbalances.
Thank you.
Yeah.
Sunil, years ago, we used to give aspirin or recommend aspirin for a stroke, like you do.
Correct.
You always take aspirin if you think you're having a heart attack.
Right.
But is it still recommended early on to take aspirin if you think you're having a stroke?
That's a great question. The answer is no.
Okay.
Yeah, and I'm glad you asked that question. That's a really important question. Because if you have the hemorrhagic kind, the last thing you want to take is aspirin. Then you already have bleeding in the brain. Now you're adding a blood thinner on top of it. And so you don't know without doing a CT scan. And I've been fooled. I've been doing this a long time. But there's a lot of, oh man, that person's classic ischemic stroke. And then we did the scan. Whoops, there's a tiny amount of blood there. I'm glad we didn't give a blood thinner. So yeah, so that's a great question. Great call.
So how is the chronic kidney disease a risk factor? I didn't quite.
Well, it has to do with the way the blood clots, and it makes the blood more thinner, basically. It also causes microvascular changes. So you were asking, I think, earlier about the thinner, weaker blood vessels with time. So it accelerates the aging, if you will, in a simplistic sense. The blood vessels in the brain makes them more what we call friable, or more
Fragile.
more fragile. That's the word. Yes. Okay. Thank you. Okay. So signs, symptoms, and signs. So does anybody know the difference between symptom and sign? This is another medical school question. So we've all heard these terms. So symptom is something that you feel as the patient. I feel dizzy. I've got numbness. I've got weakness. Sign is what I see. And it's something that's objective, it's measurable, okay? So a sign for me is, let's say you say, my leg is weak, and then I ask you to lift your leg, and then it goes like this, and then it stays up there. I'm like, you're saying you're weak, but I can see you're lifting up your leg. But if the leg, I ask the person to lift the leg up, and it just drops right back to the ground, assume I'm lying down, then you know that's a sign. So sign is so we look at symptoms and signs. And this is kind of the art of medicine. And so you've heard a lot about artificial intelligence and can artificial intelligence be better than doctors? And I would say yes in certain cases, but by far the majority, no. And it has to do with putting all of this together. So we can talk about AI. That's a whole other topic. But it's actually really cool. It's changed the way I practice medicine already, and we can talk about that.
We're having a lecture next time.
Oh, really? Okay.
Or
All right.
no, after the first of the year on AI.
Okay. So remember I talked about strokes happen suddenly. They happen all of a sudden. And it's weakness on one side of the body. And I will ask this question, do you feel weak? And it has to be one side. It's not, my legs feel weak. Okay, so well, both legs means both. If both your legs are weak, that means it's usually a spinal cord issue. Okay, and that's not a brain issue. Okay, so stroke is, for all intents and purposes, we're talking about the brain. And so it's one side of the body, it's unilateral, okay? Numbness on one side of the body, and that makes sense. So and it can be facial weakness or numbness, and then it can be the other side. But it has to be one side. It's not like I've got numbness or weakness in my entire face.
So it can be either or, right or left?
Correct, absolutely. Visual changes, so double vision. So this is something we see a lot, blurred vision, but there's a lot of things that can cause blurred vision, right? If there's something in your eye, for instance, or loss of vision. So one of our neurosurgeons was playing golf with his buddies. This is about 12, 13 years ago. He's playing golf, and all of a sudden, he was out there on the fairway. He lost half of the visual field of both eyes. And what I mean by that, he said, I can see the right side. So if you're looking at a clock, for example, you can see 12, 1, 2, 3, 4, 5, 6, but cannot see the 7, 8, 9, 10, 11 side, okay? And so, actually he had a quadrantenopsia, which is in even like the smaller subject. So it was like half of a half. So it was the left lower, I think it was the right lower side. Anyway, the rest of his exam was completely normal. He wanted to keep golfing initially, but then his other nurse said, no, that's not a good idea. That was the best stroke alert I've ever seen, man. Boy, all those doctors came in so quickly. And so we gave him the clot busting drug, and we'll talk about the new hope. The clot busting drug, and he did great. Full recovery, went back to operating. So visual changes, slurred speech or loss of speech. So there was a gentleman here. He had a little bit, probably like his early 80s, from Half Moon Bay. Had a full beard, a little bit portly, and it was November, and he came in, and this is what he was doing. He could move, he could walk, he could do everything, but he could not say a word. And so all of a sudden, so we gave him the clot busting drug, and he regained full speech the next day. And he made a full recovery. What was nice about him was the fact that he was a Santa Claus in the fall. It was just in time for Christmas, so he was able to go back and do that. So that was pretty cool, you know, getting Santa Claus's voice back. Nice ho ho ho. And then gait or balance changes. This is really important. And so you heard me talk about dizziness. So a lot of times people will walk, but they may not realize that they may have difficulty walking or stuttered steps. And it's like, gosh, something just doesn't seem right. Or they can stand fine, but then as soon as they try to move or anything, it's like, whoa, I feel like I'm going to fall. That could be a stroke. Confusion. This is tricky because lots of things cause confusion. So we talked about marijuana, we talked about alcohol. I mean, there are so many different things that can cause confusion. So, could it be a stroke? Yeah, chances are it's not based on probability because that's a wide variety of things. All right. So symptoms and signs of stroke. So you heard me talk about, you'll hear this term BEFAST, and there's some materials back there on the back table that go over the signs to look for. So it used to be just FAST, but now we've included BEFAST. So B is for balance, so some loss of balance. Okay, so if you see this, that's not normal. And especially like, it's one thing if you like get out of bed and it's just like, I'm a little unsteady for a moment, but then you quickly, regain your gait and you can go about doing your normal activity. That's not what I'm talking about. I'm talking about where it's sustained. And sustained, it's like something was definitely off. And we talked about a TIA being anywhere from 2 to 15 minutes. It could be that short, but typically people wait, okay? Because we're all denial people, you know, in that sense, you know, when it comes to our own health. Maybe it'll just go away, or it's just not funny, or something like that. But if it persists, for sure, you gotta get help. Or at least somebody to take a look at it. So sudden loss of balance, loss of vision in one or both eyes, okay? Now I remember I told you a stroke typically happens on one side of the body. So with regard to the eye and just the way neuroanatomy is, stroke in the brain typically can cause, it'll affect both eyes. Remember I told you that the surgeon can only see half of the clot face? But you can sometimes get an isolated clot to one eye, and that can be devastating. And so we can actually treat that, just like we treat it like a stroke. Facial weakness, that's a big one. So if you see half of the body, all of a sudden, or face, they can go like this. Smile for me, and you get this. And it's loss, and especially when I look here, is what we call a nasolabial fold right here. That's a telltale sign, like something's not quite right. Arm or leg weakness, that's very typical of what we see. And it's those hard findings that we see that people usually come in for help and say, oh, you know, I think I'm having a stroke. Slurred speech, or trouble speaking or seeing confusion. Again, I'm not a big fan of confusion because a lot of different things can do that. But speech is slurred. And then thunderclap, headache. T is also for time as well. They could hear a terrible headache. But worst headache of life. You heard me, there was mention about subarachnoid hemorrhage. But T is for time. You've got to get to the help, and you've got to get to the doctor as quickly as possible. So about a month and a half ago, it was Sunday evening. I was kind of winding down. I was doing some work on my computer, and my mom called me. And she told me, she's in Foster City, and she told me, you know, I just got all of a sudden a really bad headache. She never calls me at night. I always talk to her every day, but she said, this is different. I mean, it was in the back of my head. This is really bad. And I said, you probably, you know, we had gone to the store together earlier in the day. I said, maybe when we lifted this heavy box or something. She said, I said, let me call you back. I said, call me back in a half hour, or I'll call you back. And she said, okay. I said, I just don't feel that great. I said, okay. But what did I do? I kind of said, oh, whatever, you know. So it's probably muscular. No, I mean, that's what I do. Okay. So anyway, so I called her a half hour later. I said, how are you feeling? And so she said, I'm like, oh my God. I mean, and you know, me being a physician, I said, you need to call 911? No. So I live in Redwood Shores. She's in Foster City. And so door to door it takes me about 15, 20 minutes to get there. And I said, okay, you get ready. I'll come and pick you up. My son was, he's a freshman in college right now, but this is right, you know, before he left for college. I said, get in the car. I'm going to need your help. Let's go. And so I drove through every stop sign, like full speed. You know, it was dark, it was 10:30 or 11 o'clock at night. And I kind of, and if I have my badge with me, so if a cop pulls me over, I can just come say, please let me go. You know? I never try to pull a rank like that because, you know, it's just not cool. But anyway, so I got to Foster City in about 9 minutes. It only takes me about 15, 20 minutes. And she was just lying in bed. She said, I can't move. I'm like, oh my God. So I just threw her in I got my son to help, you know, carry her, and then I dragged her into the car. And I just drove, you know, probably 80, 90 miles an hour on the freeway to Kaiser Road City, which is where I work. It's the closest emergency department. Kaiser or not, I would have taken her to the closest one, but because I know people there, and we have expertise in stroke care in particular, I took her there. And so luckily, thank goodness, everything turned out okay. You know, and it ended up, she had a TIA. Which is really weird because TIAs almost never have a headache associated with it. But her blood pressure was like 220 over 100, and we had trouble controlling it and all this kind of stuff. So she was on aspirin. She wasn't on aspirin, now she's on aspirin. Then they put her on Plavix, another one. So anyway, I relay that story to you because the whole denial thing, it's real, and I get it. I've lived it, you know, but the point is, You know, luckily she's doing well, no headaches, and no neurologic symptoms whatsoever. But it was a really scary time. And so, and for me, as a physician, I'm thinking, even in real time, as I'm driving, I'm like, okay, am I going to have to get a caregiver? She lives alone, so am I going to have to, she's going to have to live with me? But this is like, these are massive lifestyle changes that happen with people with stroke. And so, these are the thoughts that are going through my head already. I'm thinking ahead, what's going to happen. And me being a physician, I've seen the worst. So I'm thinking, is she going to be bedbound? Is she going to be in skilled nursing? I mean, so these are the thoughts racing in my head, so that made me drive even faster. So, but, you know, so anyway.
So I have a question.
Sorry, I think the young lady there was first.
I witnessed a woman having a stroke in church.
Uh-huh.
She was under EMT care within 10 minutes,
Fantastic.
and the next day she was fine.
Oh, it does happen.
So,
But
the faster the better.
But to your point, what's interesting, it happened like that all of a sudden, right?
Yeah.
Okay.
So my question is, I understand you're a dutiful son,
Uh-huh.
but why did you not call 911?
Thank you. I can be faster, honestly, because I know what paramedics do. And so they'll come in, they have to figure out how to get in. She's in a chance to take an elevator up and all this kind of stuff. And I did the math in my head, and I could get her faster to the hospital, and luckily I live nearby. So I could get her there faster, and I probably saved about 20 minutes doing that. But for the majority of people, and who don't know the system, and I called ahead to the emergency department. I said, be ready, I'm coming, I'm bringing my mom, here's her number. They were ready for her. So it was, but for everybody else, and plus she was super stubborn. So.
He is not normal.
In this community, if we are administering first aid and waiting for emergency backup, what first aid do you recommend we do for our neighbors?
If they're having a stroke?
If we suspect they're having a stroke and we call because it's delayed to get them here, to get them over 92.
Right, exactly.
What first aid do you?
Well, the most important thing is to call 911. But then in the meantime, when you're waiting, is to keep their head up, making sure they can breathe, okay? What would be helpful if there's someone else is to gather the medications, because the medications are huge for me. I need to know what those patients are taking, because it really affects the treatment I render. So knowing the medications and getting past medical history. In terms of actually taking care of that individual in front of you, it's a little bit harder. I mean, there's not a lot you can do with the stroke other than making sure they've got a good airway. And then there's some information there in the back as well.
So if your mom calls you again, would you take it for granted, or would you just go over there now?
You mean like if I'm there right now? I tell her,
No, I'm just saying, if you're even at home, she calls you like she did.
Yeah.
Would you just say, okay, Mom, call me back in a half an hour again? Or
No.
Does it make you rethink?
At least I go over there and just check her out.
Right.
For sure. Sorry, I'll get you. Jen, you have your hand up?
Oh, no, it was because of the value of life, and
I
I
see.
stress for us to call 911.
Okay.
Yeah, in fact, I just wanted to say that too. The file of life is exactly what Dr. Bhopale is talking about. It is a place for you to put down all the medications you're taking, all of the chronic medical conditions you might have, so that when first responders get there, they know to look on your refrigerator for this little bag of information. So, by all means, if you don't have one, check it out at the back table, take it home, fill it out.
And update it.
Along those lines too, I do want to put in a plug, is what we call for life care planning. Think about what you want done. So some of these strokes can be pretty devastating. You have to be on a ventilator, you have to go to the operating room, all those kinds of things. Is that something that you would want done or not? And so if you have your advanced directives out ahead of time, super, super helpful there. So yeah, it makes a huge difference. For us as physicians, knowing that, that's super helpful. There have been times I've had patients come in with an acute stroke and the family says, no way, they did not want this person to be in the ICU. They said, don't give the clot busting drug. We'll talk about that in a moment. It's like, okay, I mean, we honor the families, really the patient's wishes. So that's super, everybody's different. And people change their minds.
But if
People change their minds.
if there's a DNR in place,
DNR does not mean do not treat. So DNR means if somebody has an arrest right in front of me, okay, they don't want anything done, okay? That's it, they want natural passing, okay? But if, so that means do not resuscitate. Resuscitate means you start pushing on the chest, you put a breathing tube down the throat, you shock them if they have a shockable rhythm, that kind of thing. You know, the zap on TV that you see, that kind of thing. But DNR does not mean do not treat. And I put DNR patients in the ICU. So a stroke, most of these people survive. And, you know, if, let's just say, you know, you're, not you in particular, but someone is DNR, but they come in and they were just playing tennis or they were playing bridge, and then all of a sudden they have trouble speaking, doesn't mean I'm not going to treat them. I can give them the treatment, I can get them in the ICU, they can get better, and then have a happy and fulfilling life for several months to years. So that's an important distinction. Yeah.
Just because, unfortunately, he just walked out. But remember Matt?
Yeah.
Matt had full arrest, completely. He was dead. And fire department came and resuscitated him, and he walks every day, he's out and about, he has full function. So you can't assume because somebody had an episode of something that they won't return full capacity. And my DNR on the refrigerator says that I want to be resuscitated if there's any chance I can return to normal function or to good function. So it's a matter of
Yeah, there's important distinctions, and it's important to have that conversation with your physician.
Yes.
Okay.
How important is it to have that list of medication if you know you're going to the facility, whether it be Stanford or Kaiser, that has your medical record?
So,
and they can
great
fill it out?
question. So I get this every time, because we ask every patient when they come to the emergency department, every time, what medicines do you take? Because you know what? They change it.
Yeah.
They change the dosing. They forget certain things. Or I stopped taking that blood pressure medication because it caused a cough. You know, and they don't tell us that. So even though it may be in the computer system, it may not be accurate. And so I need accuracy because that can change my management minute to minute. You know.
But they go through it with them though, once you
We
come
do.
in, right?
We do.
Then you ask.
They take the little green pill and the little
Right.
pill.
No, good there.
But not every stroke patient can talk.
Right.
Yeah, we better move ahead because we've got somebody coming in after us.
Oh, wow. Okay. So if you if somebody's in front of you, right here, right now, you're worried that person might be having a stroke, these are the things to remember in terms of what you ought to do. So like I said, not everyone's going to jump to 911 as soon as someone says, I feel dizzy. So ask them to repeat sentences. Smile and open and close their eyes. So look for facial weakness or any issues with their vision. Raise both arms and see if they can be held. Okay? Raise each leg and see if there's any drift. And what I mean by drift, I'll use my arm as an example. It's like this. It slowly starts to move. Sometimes it's like limp. And by far, the most important thing is can they walk? Now, it's problematic if they get around with a walker or if they're wheelchair bound. But walking is by far the best neurological test to tell if someone at least has what we call a motor deficit. You remember my Mr. Santa Claus? He could walk, he just couldn't talk. So that's the other thing. Can they walk and talk? You know, so it's super important. Let's see, we'll keep going. I think we're going to have to skip the videos because we're running pressed for time.
Well, the other thing doesn't start till 1, so I think we have.
Yeah.
Knowledge starts at 12, doesn't it?
Yeah, Suki
No.
came and said we're fine on time.
Okay.
So we're good.
Okay, is there a question back there?
No, let's get it done.
Oh, okay, all right. Okay, so misconceptions. So loss of consciousness is often a stroke. So you've seen this over and over again. People pass out in the dentist chair when they hear bad news. Sometimes after a coughing fit, going to the bathroom, very, very common. Is that a stroke? Usually not. So stroke, remember I said it affects usually half the body, and that means the other half is still kind of able to function. And so it's rare that stroke causes a loss of consciousness. Loss of consciousness means not enough blood flow to the entire brain, okay? So, for example, if somebody it's a hot day and then they went for a run or something like that, what happens? They get dehydrated, they could easily pass out. That's different, that's not a stroke, okay? Memory loss means you're having a stroke. Well, you know, I think all of us at some point have found this, but it's usually, memory loss is not, that's dementia, that's a different problem. And that's much more gradual. Stroke involves both sides of the body. So, you heard me talk about leg weakness. I'm having difficulty walking. It's usually one leg. It's not both legs. So it can involve both sides of the body if it crosses at the neck. So sometimes you can get, let's say for example, right leg weakness and right arm weakness and left facial weakness. That does happen. But again, it crosses at the neck. But typically, stroke is almost always one side of the body, either the right side or left side. Stroke is painful. Almost always it's not, unless it's the subarachnoid hemorrhage or that other kind of blood vessels rupturing. Those people tend to typically complain of a headache. But usually the ischemic kind, no headache, no pain. The brain itself is responsible for perceiving pain, but does not have any pain fibers in and of itself. So you've heard of examples, or you may have heard on TV, when they're doing brain surgery, when you cut through the skull, yeah, that hurts. But when they're actually cutting the brain, no pain. So strokes are not painful. A headache means a stroke is likely. No. So we get headaches all the time. It's usually due to other things, but it's typically not a stroke. Strokes only happen to the elderly. That's false. So we do see it in children. It's rare, but we do see it, and there are reasons for it. I'm not going to get into it at this time, only because of time. Strokes are not preventable. They absolutely are preventable. Super important. There is no treatment for stroke. False. There is treatment for stroke, and we'll talk about that. If stroke symptoms go away, you don't need an evaluation. So I hope by now, with the different stories I've shared with you, I've convinced you, it's really important to seek medical attention, especially if the symptoms, even if they've gone away, you do need to see a doctor. And stroke recovery only happens in the first few months. That used to be the old adage, but sometimes we've had patients recover and make almost complete recoveries a year out from the original stroke. So these are, for the most part, false. Okay, what about stroke mimics? So are there other things that could be a stroke? They look like a stroke, but they're not a stroke. So by far, sepsis is one, and you may have heard of this term called sepsis. So that means a severe infection somewhere in the body. By far, the most common areas are pneumonia, lung, and urine, in urinary tract. And so we see that, but it could be a skin infection, it could be an infection in the gut, cholecystitis, that type of thing. Seizure, very, very common. You can have what's called a focal deficit, where they can't move a part of their body, but it's a seizure, it's not a stroke. That's where you need to see a doctor for sure. And even I sometimes have a hard time figuring out if the patient's having a seizure or a stroke. It can be very difficult. Syncope, or passing out, that's not a stroke, typically. That's something else. It has to do with blood flow to the brain, but the entire brain, not just part of the brain. Low or high blood sugar, very common. So we check this all the time. Paramedics can do this. They'll check your blood sugar if you call them with stroke-like symptoms. Complex migraine. So I had a 26-year-old lady come in. I saw her like 2 or 3 times. Excruciating headache, but she just could not move half of her body. I thought, man, that looks like a stroke. And then, got the CT scan. We're thinking about giving her a clot-busting drug. And then I gave her treatment for a migraine, just because I know, and I had seen her before, she got better every single time. And so that particular patient, I was lucky I had that relationship with her, that I knew that it was a complex migraine. So these can be tricky. Medications, there's certain medications that can mimic a stroke. Psychiatric causes, so sometimes people can get, that's a diagnosis of exclusion, by the way. We always believe the patient, but sometimes it can be an anxiety or stress reaction. Benign positional vertigo, that's an inner ear problem leading to dizziness. Bell's palsy, it's a weakness in the facial muscle, the facial nerve that leads to drooping of the face. It can look just like a stroke, but it's not a stroke. And that's just an isolated treatment, and you get to go home, which is really cool. And then brain tumor. But brain tumor comes on gradually, typically. It doesn't come on all of a sudden. All right. So what did you do when calling 911? Stroke is a seconds to minutes emergency. If you see any signs or symptoms of stroke, call 911. Note the last known wall time. You were the past. That's actually really important. So there was a question about when did the symptoms start? And I asked that question I asked it multiple ways and in different ways. Okay, I woke up with it. Okay, so when you went to bed last night, when did you last feel okay? Well, I went to bed at 10 and I was able to walk and go to the bathroom and brush my teeth. Okay, that sounds pretty good. Did you wake up in the middle of the night and go to the bathroom? And many of us have to do that. And if you did, chances are that was your last normal time, not 10 o'clock, but maybe 2 in the morning. So that's super, super important. Wake-up stroke in particular is potentially treatable, and knowing the last normal time is super important. Past medical history, bring all the medications, a list is fine. And then patients who come in by 911 are generally treated faster, unless your son is an emergency physician. Don't follow my example. Let's see here. Let's go back real quick. Okay, so San Mateo County. So you've got, we're right here, Afib Bay, right here at the bottom. There's 92. And then, so you've got a couple different medical centers. I wasn't able to put Stanford here, but they're technically in Santa Clara County, but they're right here, the southern end of the county. Then you've got Sequoia Hospital right here. You've got Kaiser Redwood City here in Redwood City. Then you've got San Mateo General. And then, let's see, San Mateo General is not a stroke center. They can initially treat and evaluate patients somewhat, but they really, they send those patients.
Is that Mills?
No, that's over here. That's Peninsula Hospital up here. That's Peninsula Hospital. And Mills is a receiving center for paramedics, actually closed.
Paramedics won't take you, if
It's
you
a
call
clinic.
911, paramedics know where the stroke centers are.
Right. And then in the north part of the county, you've got Kaiser South San Francisco and then Seton Medical Center. So there's two hospitals on the north end, Peninsula, which is kind of on the northern part, in the northern central. So 3, Kaiser Redwood City and Sequoia, 4, 5, and then Stanford, 6. So these are the 6 hospitals that are stroke centers in our county. There's different levels of stroke care that are provided at these hospitals. All of these are considered, there's a term used by a medical certifying organization called the Joint Commission. They're all primary stroke centers, so they can all give clot busting treatment, and we'll talk about that in a moment. But these 2 hospitals, actually 3, Kaiser Redwood City, Stanford, and Peninsula can actually go in with a wire and take the clot out if they identify patients that are appropriately candidates for that, and I'll show some videos about that. The other thing is, so these 3 hospitals can actually take the clot out physically, and then Redwood City, Kaiser Redwood City, and Stanford can actually do operations. They're actually do neurosurgical care too, especially if there's bleeding in the brain. So anyway, but all of them, by far the majority of patients will get excellent care at any of these hospitals.
Yes, and of course, we're not close to any of those.
Correct.
And that's a source of a little anxiety about that. Out here on the coast side, what options do we have?
I would say to call 911, but the quickest thing, so when a patient comes in with stroke-like symptoms to the emergency department, the first thing I try to do is get them to that CT scanner as quickly as possible. Because if they've got blood in the brain, I'm going to go down one treatment pathway. If they don't have blood in the brain, which is the majority of the time, they're going to have a different pathway. So what happens in the emergency department? So, yeah.
Just real quick, call 911 if there's a problem, or if there's a problem with, say, 92 or double slide, they'll contact the helicopter to take you to a stroke center, because stroke is a 911 emergency.
Seconds to minutes.
So they want you to, they'll recognize it and get you to the appropriate facility.
Yeah, you're fortunate you have someone with EMS connections here to make sure that all of you are plugged in, yes.
With the stroke ambulance, I know that I've been in the presence of someone that had a stroke, and it happened that they sent the stroke ambulance. Is the stroke ambulance able to come to the coast?
I believe so, but
Yeah, I've asked that question, actually, it's a pretty cool thing.
Yeah.
But it was paid for by, I think Peninsula Healthcare Foundation, and it's stationed there. So, plus there's only one of them. So they can come over to the coast, but they have to be available. So it's not a surefire resource.
It's a 9 to 5 Monday through Friday type of thing.
Yeah, it is a 9 to 5 resource
So
also.
it's a research protocol. So you heard me say, when somebody comes in with stroke-like symptoms, the thing I try to do is get them as quickly as possible to that CT scanner. So what the question is, what if they brought the CT scanner to you, where you are?
Right.
So what if the CT scanner came here? And that's what they do. And then when they identify a patient with a potential stroke, then they can give the clot-busting drug in the ambulance itself. So now there's certain advantages and disadvantages to having a machine like that. And basically you're talking about a mobile CT scanner is what you're talking about.
Yeah.
So obviously that ambulance is not a normal size ambulance, it's a little bit bigger. And there's certain pros and cons to that concept. I think it works well in certain areas, and others it may not be as beneficial. I mean, obviously it would be great if we could do that kind of treatment for all different types of conditions, but there's a cost-benefit factor involved too in terms of what a resource like that would cost. I think. Yeah. Was there another question?
I just had a question. Is there any way for a doctor to tell that, oh, you had a previous stroke?
Yeah, so there is, if that person still has what we call a deficit, or if that person still is having an issue. But there are many times patients can make a full recovery, and I may not know as a physician. And I have to look at the chart and say, oh, I see you had a stroke in the past, but you made a full recovery.
So there is your brain, I guess, it does.
Sometimes it can rewire in the part of the brain tissue that died off. Other parts of the brain may be able to compensate. Again, it depends on how much of the tissue that died off. Or if it was a mini stroke or TIA where none of it died off, but it was like sending alarm signals that things aren't quite right. But it can be difficult to tell sometimes. Sometimes it's very obvious. But I've been humbled enough doing this job for a long time that I rarely make assumptions about people having had a stroke in the past or not, just based on history and exam. It can be really tough.
Okay.
Sorry, there was another question.
I noticed that you didn't mention the VA hospital in Palo Alto
Yeah.
as a stroke center.
They're not a stroke center.
They're not at all. Do
Just
they have
like-
doctors there?
They have emergency doctors there, but and they can also give the clot busting drug, and we'll talk about that real soon. However, it's not recognized as a formal certification by that certifying body that I refer to as a joint commission. So it's not that you won't get stroke care, you can definitely do the CT scan, but then after that, that's where it becomes a little bit different, and things may be more delayed than if you were to go to a private stroke center. Okay, so what happens when the patient comes to the emergency department? The nurse usually does a screening of the patient because they're usually the first ones to see the patient. The emergency department physician will do a stroke assessment. We'll check a blood sugar. Remember I talked about stroke mimics. Get a CT scan of the head. That's very, very quickly we try to do that. Then we do the blood work, get an electrocardiogram. I'm looking for that irregular heartbeat called atrial fibrillation. But that's ancillary data. I don't need it to actually determine what I'm going to do here for the patient. And then we'll talk to a neurologist. And what's happened in the past 10 years or so is telemedicine. So now, it used to be, when I was first starting this practice, I'd have to get a neurologist, he or she seeing a patient in the clinic or in the hospital, drop what you're doing, come to the emergency department right now and evaluate this patient. Like, how practical is that? Not very practical, right? They're taking care of their own patients. So now they can just say, excuse me for a moment, and then they'll come and they'll just beam in, looking on their phone or on an iPad-like device. They can beam in and look at the patient with me and just say, yeah, that looks like the real thing, but that doesn't. So even though I'm an emergency physician, I've seen and recognized hundreds of stroke patients. Sometimes it can be tricky and to determine just based on exam whether or not a patient's having a stroke. So, and it's helpful to have a thought partner with me. So a neurologist is very helpful. And in that mobile stroke unit we were talking about, they don't give treatments without a neurologist being involved in looking at the patient. So it's not just we're looking at CT scans saying, oh yeah, that person's good to go, get the treatment, this one is not. We actually have to examine the patient. And then we review treatment options. So let's see. So general prognosis. So in general, this is a rough approximation. If you've had a stroke, about a third of the time it will get worse. About a third of the time, it is what it is. What you see is what you get. It won't get better, it won't get worse. And a third of the time, it will actually improve. This was like the old paradigm. I would say it's starting to shift now a little bit, and it's probably shifting more in this direction, where we're starting to see a little bit more improvement and a little less staying the same, and a little less getting worse. So that's the good news. So things are actually getting better because of the treatments we've got there. So if you've got strokes that are caused by a blockage of a blood vessel or an ischemic stroke, you have a couple of options. You can do nothing. That's always an option, right? And so the path of least resistance. Blood pressure control, blood thinners, we talked about aspirin and how people are taking aspirin, anticoagulants, thrombolytic drugs. So thrombo means clot, lytic means lysis, means to dissolve. So dissolving clots, that's what that is, and we'll talk about that. Cholesterol-reducing medications, statins. So I never understood this from a pathophysiology standpoint. So say somebody comes in with a stroke, we start, and if they're not taking cholesterol medication, we start it right then and there. In the emergency department, or as soon as they get up to the floor upstairs, we'll start them on statins. And statins typically take days to weeks to work, before you start seeing lower cholesterol levels. What we found though, you administer statins sooner, patients actually recover faster. And we don't fully understand why that is, but it works. So that's why we do it. It's interesting. Thrombectomy. So thrombus means clot, ectomy means to take out. So we've got different devices to actually go and take that clot out. And then surgery to decompress the swelling. We talked about swelling in the brain from those blood vessels rupturing, and then carotid surgery. So, okay, so for hemorrhagic strokes, so this is the bleeding kind of stroke variety, so you can do nothing. Sometimes we do very minimal treatments depending on how the patient looks. And the patient can oftentimes look quite good. Blood pressure control, so generally you want to get that blood pressure lower, because if you've got higher blood pressure, that's going to cause more blood to squirt out into places it shouldn't go. Drug reversal agents, especially for blood thinners. So if if you're taking a blood thinner, you can give a reversal. That's sort of like what happens with snake bite. An analogy. So snake bites, you've heard of venomous snakes, and when they bite, there's neurotoxins, and then there's anticoagulant not medication, but venom. And so snake bite, well, it has to do with antibodies. It actually reverses it by binding onto there. But the idea is to stop the reversal of bleeding. Coiling. So if you've got the aneurysm, that balloon I talked about, off a blood vessel, you can actually put a wire in there, and then that actually will promote clot formation, and then surgery to decompress bleeds and reduce swelling.
So swelling, does that mean you guys drill through the skull to release pressure?
Yeah. The surgery means, you're going to have to make a cut through the skull. Yeah. So there's treatment options for stroke. So almost 30 years ago, in the New England Journal of Medicine, which is considered the premier medical journal, academic medical journal, there was a study done with Alteplase, which is a clot-busting drug, and it was originally designed to build a plaque, to break up plaque buildup. It was really for a clot pipe, and so literally you just kind of pour it in there and it actually dissolves it. And so it was. Actually, now I need to update this. It's the only FDA-approved medication for acute stroke. That's not quite true. There's another one that we use now. It's manufactured locally in South San Francisco, Genentech. And then one dose is $5,800. So sometimes, and it comes in powder form. So if we think we have a patient who's having a stroke, we put the sterile saline in there. That's that sterile saline right there. We mix it in there, reconstitute the drug, and then deliver it. We can get it to the patient usually within 10 minutes.
So does that mean just one dose, or could it be multiple doses?
So Alteplase, good question. So this is typically what we call a bolus, a one-time push, and then a drip. You would hang it as a drip. Since this, this slide, we've actually switched to a drug called Tenecteplase. Same type of drug, but it's a one and done type thing. So you push it once, and that's it. No need for a drip. So actually, that's on the next slide right here.
And the your insurance will usually cover
Yeah.
part or all of the costs.
Yeah, you don't have to bring a checkbook. You feel like it, but you don't have to.
We'll find you, we know where you live.
Yeah, exactly. And I want to make something really clear. When you call 911, the hospitals are not out there with saying, how are you going to pay for this? We take care of the patient first. Don't worry about the finances. You know, we take care of the patient first. So Tenecteplase, it can be given up to 4.5 hours from the last known dwell time. So that's super important. There's strict inclusion and exclusion criteria that I'm not going to get into. But if you've had a previous, for example, hemorrhagic stroke, a bleeding of the brain, now you come in with an ischemic clot, that's a little risky. You remember the analogy I talked about, the piece of rotted fruit or whatever? Do you want to really put a clot-busting drug in blood vessels that are a little bit thinner, right? Not such a, there's risk and benefit. It acts within minutes, which is really great. Sometimes it can take a little while to take effect, but I've seen people who couldn't move their arm, all of a sudden they're able to move their arm after getting this drug. Obviously, the sooner you give it, the better the result you're going to get, and for every 15-minute delay, the odds of improvement decrease by 5%. So the clock is ticking. That's a really important point. And our goal is to get it says 45 minutes. Now, routinely, at least half the time we're getting in 30 minutes or less. The fastest we ever got somebody in, somebody walked in saying, I'm having a stroke, I think it was 12 minutes.
Wow.
That's the lightning. If you think you have to get a CT scan, you have to get the drug ready, it takes 10 minutes to make the drug, you got to get an IV, you got to push 12 minutes? That's unbelievable. So, but it does happen. Yeah. So only about 5 or 10% of all stroke patients receive thrombolytics, though. Most don't, because either they're not candidates for it or they're not having the right type of stroke for it. So it's not for all strokes. So yesterday, I was working a shift, and it was 2 o'clock in the afternoon yesterday, and I had a couple patients in the tie-up. I hadn't eaten lunch yet. I had breakfast at 7 in the morning. So I'm looking forward to lunch. It's kind of busy in ED, and then the nurse says, MD alert, I need a doctor. So why did I walk right by there? So, because there's other doctors, and the new doctor was just coming on that too, but I heard it. So, what's going on? And they said, this guy can't move his left side. So, it was his left side. So, it was a 55-year-old gentleman. We were able to determine, there's a little bit of a language barrier, but he spoke enough English. He said, I started having trouble moving my left arm and left leg at 9 o'clock. And then I'm thinking, wow, it's already 2 o'clock. So right now I can't give him the clot-busting drug. And I said, lift your arm up. And then he would just drop right to the ground. Same thing with the leg, lift your leg. This is not good. So I called the teleneurologist, and even though I couldn't give him the clot-busting drug, I said maybe he's got a blood vessel in the brain that has a big clot, and maybe we could take that out. So we went down the stroke alert pathway. He ended up having some slurred speech as well. And what else did he have? Those are the main findings. So we got into the scanner. We did a quick CT scan. He didn't have an obvious stroke. It looked normal, actually. So then we actually squirted some IV contrast and then did another scan of his brain, looking to see if there's any blockages in the main blood vessels supplying the brain. And there wasn't. So unfortunately, there was no treatment for him other than starting the statins, the aspirin, all that kind of stuff. And it is what it is now, unfortunately. He waited too long. And that's the part I have a hard time reconciling, because had he just come in half hour, 45 minutes sooner, I could have given him the clot-busting drug, and potentially we could have done something. Now, I could have given it anyway, but then the risk of bleeding gets much, much higher, because those blood vessels start to die off. And so then they have an increased risk of bursting if I give a clot-busting drug. So that's why there's that time window.
So you shouldn't lie.
Don't lie. No. Unless you want to just say, I'm going to try and win the lottery here, I'm going to go for it.
I mean, it's tempting when you know that you're close, it's like,
but if you've got a pretty good chance of making a full recovery anyway, then why can't I take that risk? And so, I'll tell you, most neurologists were really gung-ho about this when this treatment first came out, and most emergency doctors are firmly opposed. We did not, I mean, do you want to take the risk of that kind of medication? Now the paradigm has shifted, so emergency doctors and neurologists are all supportive of this treatment. There was a lot of skepticism about this. And you don't know what you don't know, because we didn't do it before until 30 years ago. But now, it's over and over and over again, that we found that it is an effective treatment in the right circumstances.
Why were they skeptical? Is there some kind of side effects after that or something?
Well, go for it, and if you have a bleed, you've turned a minor stroke into a potentially devastating one. Let's just say you, for example, you could barely lift your left arm, or you could lift your arm a little bit, or there's a little bit of hand weakness. Something you could probably live with, but it depends on what you do.
Right.
You know, if you are a computer programmer and you need that hand, that's a big deal. If you are, do another line of work where you don't need that, maybe it's not as important. So it all depends. And everybody's got a different comfort level and threshold.
Yeah, because I have an uncle that had a stroke, and he's on a cane and can barely walk or lift his arms.
Right.
That's pretty bad.
Right. So he or she might be, your uncle might be okay with that. Just say, hey, I get to be with my family. I can still engage with other families. Other people say, you know what? Count me out, man. I don't want a life like that.
Right.
So everybody's different.
Everybody's different.
Yeah, everyone's different.
Now, is a stroke one of the symptoms, or do you have numerous symptoms before you can say, okay, I'm having a stroke?
It could just be one symptom. So for like the example I shared with you about the neurosurgeon, it was just a loss of vision. Just a part of his field of vision. That was the only symptom. So it can be very subtle. But it's usually a consolation. Like this gentleman had left arm, left leg weakness. He had obvious slurred speech. Oh yeah, that's right. And then part of his face was a little bit weak too. So it was obvious. Oh, okay. Let's go back here. Okay. So, without getting into too much detail, thrombolytics have their risks and benefits. So most of the patients who give that clot busting drug, they're going to be unchanged. 3 will get a little bit worse, and 3 out of 100, and 1 will actually get a lot worse. So this drug is a little bit, I don't want to say Russian roulette, it's not. It's safe, but it's safe in the right circumstances. I have seen bleeds as a result of the thrombolytic drug being given, but it's pretty rare. So that's what the initial emergency medicine doctors, they were skeptical about this group. They were also a little bit skeptical, are we really treating stroke or not? But we found these light green ones, the majority of patients improved, and the dark green ones had significant improvement. So about a third of the time you'll get better. So that's what the literature shows about thrombolysis with stroke. There's also another treatment where you can go in. If you think about it, if you've got a clot, and either it's due to plaque buildup in the artery, or if it's due to an embolism, what we talked about atrial fibrillation earlier, going to a part of the brain, you can actually get the clot out. And it's up to 6 hours for all, LVO stands for large vessel occlusion, or all major arteries supplying the brain. But sometimes up to 24 hours out, you can actually get that clot out. So that is different. That's a game changer. And that has dramatically changed the stroke treatment. So we have dedicated doctors that all they do is just clot retrieval. And they were doing, their life was really good until about 2019, when these papers came out, 2018. And all of a sudden now they're getting called in a lot more to do stroke retrieval. So it's good for all of us, not so good for them, because they were doing, at Kaiser, I can tell you, we do over 200 cases a year of these kinds of clot retrieval cases. So about, two every 3 days or so, more or less. Whereas, we're one of the busiest facilities to do this kind of procedure. Other facilities, they do 1 or 2 a month of that. So it's not for everybody, but under certain conditions, you can actually get the clot out. These are all very brief, they're about a minute or 2. So here's a clot. So you see this wire, and this is the catheter, so this is the plastic sheet. So you can see the wires pushing through, and then you see this, it's like a corkscrew device, and then it goes into the clot.
That's interesting.
It comes out like that.
Is this real or a simulation?
No, this is simulation.
Oh.
Yeah.
The real thing is a little smaller.
Yeah.
So that thing actually coils by itself, or is that?
Correct. It's naturally coiled, but when it's in the
So when it's
plastic bag-
released, it just coils up where?
Exactly.
And then you're pulling that out like that?
Yeah. So they make a puncture through the groin, okay, and then they go up, they bypass the heart, it goes right up to the brain. So as you can imagine, there's very few places that can do that kind of procedure. So that's that right there. Here's a different kind of clot retrieval. It's kind of similar.
Put them in the shower.
So,
See that movie like kids see that movie. It's so good.
so here's the clot, here's the wire. Yes. Now, this is, it's actually going, this is
Going through it.
aspirating, so it's going to suck it like you're drinking out of a straw. Yeah, so it's like literally poking at the clot, and then it's like literally
Breaks it up and brings it in?
yeah, like that. So the term we use is aspiration, it's sucking it out, basically.
Now, is that the one in the brain?
Yeah, these are all the same, it's the same type of procedure. These are clots in the brain, and there's different ways to get these clots out. So,
That's a long way.
yeah, so just think of it as, literally it's like a vacuum cleaner almost.
How long does that take you? How long does it take?
So if you got, depending on the clot where it is, especially the closer to the base of the brain where the blood vessel is bigger, and you can sometimes get it out in 10 minutes. Our docs are lightning fast.
And what kind of anesthesia?
It's in between general anesthesia where you have to have a breathing tube in the throat
Right.
versus what we call procedural sedation, which is a little bit lighter where you give a couple of drugs. It's like a moderate level of anesthesia. I find the videos really interesting because it kind of helps.
Position the balloon guide catheter as close to the thrombus site as possible. Connect a rotating hemostatic valve, or RHV, to the fitting of the guide catheter, and then connect the continuous flush. With the aid of a suitable guide wire, hold the guide wire in place and advance the microcatheter. Position the microcatheter distal to the thrombus, so that the usable length portion of the Solitaire FR will extend past each side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the Solitaire FR until its distal markers line up at the end of the microcatheter. To deploy the Solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the Solitaire FR in place until the microcatheter tip covers only the proximal marker of the device. The usable length of the deployed Solitaire FR should extend past each side of the thrombus. Tighten the RHV around the microcatheter. Angiographically assess the revascularization status of the treated vessel. Inflate the balloon of the guide catheter to occlude the vessel. To retrieve thrombus, slowly withdraw the microcatheter and Solitaire FR as a unit to the guide catheter tip, while applying aspiration to the guide catheter.
Yeah, it's
What are the odds of somebody puncturing through it?
That's a risk, to your point. That's definitely a risk.
Okay.
The other thing is, you saw them, they're pushing that clot, right?
Mhm.
Well, what happens if that clot breaks off and goes even further? Well,
Right.
That's a risk too.
Right.
So it's not like we can just kind of go in there and just, everything's risk and benefit here. So this is what it looks like. You just saw this, right? So you can see the catheter, you can see that cage-like device that came out, and they pulled out the clot. So it almost looks like something you find if any of you have had a nosebleed and you get a clot out of your nose or something. That's kind of what it looks like. And if you feel that clot, it feels almost like the jelly from a jelly donut. A little bit thicker than that, but it doesn't take a lot. But when it affects a blood vessel in the brain, that's a big deal. So that's what it looks like. We also talked about, sometimes you can also get, you may have heard of people getting what's called a carotid endarterectomy. So the carotid artery can get a lot of plaque buildup here, and sometimes that plaque can break off and go to the brain. So we talked about atrial fibrillation. It can also happen in the carotid artery. So you can get surgery to actually remove that plaque over there, right there. You can see it almost literally looks like a thick yellow, cheesy-like material. And then you can do surgery around there. Now we've got treatments. You can also do stenting, where you can actually, instead of, you see the plaque over here, the plaque buildup, you can actually just put a cage here and it actually pushes it out once you, in that way. And so that can restore blood flow that way. So that's pretty cool how that works. We're almost done. You can see right here, angiographically. So you saw those beautiful pictures and those illustrations in the videos. You can see right here, this is what we see. Oh no, what happened here? Let's see. Okay. I don't know why it's saying that image there. Anyway, there's a blockage of the blood vessel, and then when it gets opened up, you can see all the blood vessels beyond it look okay. So do you see that right there? How it's blocked, and then let me move the cursor over.
Oh, there you go.
There we go. Okay. So,
And that's a big artery.
yeah, that's a big one. But that's, if you think about it, how do the doctors actually see this? You're looking at a two-dimensional image here, but vessels go in three different directions. So they have what's called a biplane. So they're looking at two different screens at the same time. They're constantly going like that. And then how do you get the wire to actually turn right, turn left?
That's my next question was
It's like a joystick, that they've got there. So it's really amazing. It requires a lot of dexterity. You see them kind of going like this, turning like this.
It's just, how's that bend though? How's that get that hook?
There's like a little motor, or there's ways to kind of curl the tech. Yeah. So.
Do they practice by playing video games?
I don't know about that.
Probably raising a whole new crop of really, really good neurosurgeons.
Yeah. Let's see. Okay. There's a coiling video. I can show you this at the end. There's a time that's going here.
No, it's fine. You can show it now. We're good on time.
Okay. All right. So, let's see here.
Because it's one of the coolest parts.
This is the last page.
Endovascular embolization is a minimally invasive technique performed to treat brain aneurysms. The goal of the treatment is to block blood flow into the area.
1 second here. I think it's how you should the display. Oh, I see what happened here. There we go. Okay, there we go.
Endovascular coiling, or endovascular embolization, is a minimally invasive technique performed to treat brain aneurysms. The goal of the treatment is to block blood flow into the aneurysm and therefore reduce the risk of aneurysm rupturing. In this procedure, a catheter, guided by a wire, is inserted through the femoral artery at the groin and threaded all the way to the affected brain artery. The guide wire is removed. A microcatheter carrying a soft platinum coil is introduced inside the initial catheter and is navigated into the aneurysm opening. The coil is then deployed into the aneurysm sac. A small electrical current is passed to detach the coil from the catheter. It may take several coils to fill the aneurysm. The coils induce blood clotting inside the aneurysm and seal it off from the artery. In some cases, when the neck of the aneurysm is too wide, a stent may be used to keep the coils within the aneurysm sac. Stent-assisted coiling involves permanently placing a stent in the artery prior to coiling. The stent acts as a scaffold inside the artery to hold the coils in place.
The last thing you want is this coil to break off and then go further up the brain, right?
I understand. How does the coil prevent
Why does the coil stay in there?
What's that? Why does it stay in there? So it forms a clot in there, and then, but it effectively becomes like a wall, basically. So
it won't go back into the...
Right, the blood won't go in there because it's clotted off, basically.
How come you don't take them out like the other ones? Because of the bubble and the bubble?
Because that coil is inside a thin walled sac that's prone to rupture.
So if you were to take it out, that
then
skin would just flatter.
Exactly.
So is that done like in place of where if you have
an aneurysm,
an aneurysm and then like they say, let's watch it and
Exactly.
do every 6 months or whatever?
Exactly, yeah. They do surveillance and testing to see. Yep, okay, ongoing research. Okay, so new hope for stroke, neuroprotection. So we're investigating treatments that can protect brain cells from further damage. So new treatments, drugs, further ways of opening the blood vessels to the brain, rehabilitation advances using robotics. So as part of the rehab therapy, for instance, virtual reality stimulating the brain so that it works in different ways and can improve stroke function. Mobile health technology using your phone or your devices. Did you go for your walk today? Did you notice your heart was beating a little bit fast or irregular? Those kinds of things. Stroke risk prediction, better predictive models looking at genetics, lifestyle, and environment. So this is using AI to take a look at. Now with electronic medical records, there's so much data out there, we can start to understand, are there patterns that can predict which patient is more likely to have a stroke or not? So we're using AI for that purpose. I actually generated this list using ChatGPT. Inflammation and immune response, in part. And so what can we do to reduce inflammation? And then diversity in stroke research. So typically, there's certain populations that were studied in the past, but now we're trying to expand this to different people of different backgrounds and trying to reduce bias in stroke research. So this is another area of interest. Let's see. Okay, so prevention of stroke, lifestyle modification, there's blood pressure control, blood sugar control, avoiding obesity, of course, no smoking, active lifestyle, plant-based diet, vegan, green vegetables and spices. Let's see, antiplatelet therapy, we talked about blood thinners, and then statins. And you heard me talk about statins. So those are the different therapies there. Super important. But I mean, this is not good just for stroke, it's for so many other things as well, right? Let's see. So key takeaways. So stroke is a preventable disease, okay? I want you to walk away remembering that. Best treatment is aggressive risk factor management. A healthy, robust lifestyle and attitude. And that part is really important, attitude. I just see this a lot. As people get older, attitudes can change. People can become pessimistic sometimes. Having a positive attitude, but realistic, I think is important. Taking on new endeavors and challenging yourself. The journey will be the reward, not the end point. Proper nutrition and diet. Regular aerobic exercise. And by aerobic, I'm not saying, go for a run or hop on the elliptical. I mean, a walk is terrific exercise. One of the single best things you can do. Even a few minutes a day. Huge, huge difference in terms of mood elevation, in terms of your overall health, and then in terms of lifestyle modification. High level of mental activity. These are things all of you, I'm sure, are aware of. Let me see. Stroke is a seconds to minute emergency, times brain, and to call 911. And then acute stroke treatments are available, but they depend on many criteria. And most patients do not get the clot busting drugs or clot retrieval that we saw. But they do get treatment. It just may not be the exciting ones, but there's treatment.